Morning, students. So today's class is on diabetic retinopathy. Retinopathy is the most important ocular complication of diabetes. The diabetic retinopathy is more common in type 1 diabetes when compared to type 2 diabetes. Proliferative diabetic retinopathy affects 5 to 10% of diabetic population. Type 1 diabetes are at particular risk with the incidence of 90% after 30 years. What are the risk factors of diabetic retinopathy? Risk factors include duration of diabetes, poor metabolic control, and pregnant women, comorbid hypertension, nephropathy, and obesity and hyperlipidemia. The duration of diabetes. So, patient with diabetic before age of 30 years, the incidence of diabetic retinopathy, that is 50%, risk factor is 50% after 10 years of diabetes. And it is 90% in patients with duration of 30 years of diabetes. Poor metabolic control. Poor metabolic control, it is which can be seen by titrating, from HbA1c level. There is increased HbA1c level, the more than 7, in case of uncontrolled diabetes. Pregnancy. Pregnancy is associated in diabetic gestational diabetes. It is associated with a rapid progression of diabetic retinopathy. Hypertension, which is very common in patients with diabetes type 2. And there is BP should be controlled less than 140 by 80 mmHg. So there is diabetic retinopathy, nephropathy can be present. So nephropathy when present, it shows there is worsening of diabetic retinopathy. Renal transplantation. Hyperemia. Other risk factors include obesity, increased BMI, high waist to hip ratio, hyperlipidemia, anemia. What is the pathogenesis for diabetes? Pathogenesis includes microangiopathy. So, microangiopathy, there is the tight junctions of endothelium are lost, and there is microvascular occlusion, microvascular leakage can be seen. So, fundus picture of a diabetic seen in diabetic retinopathy patients, where you can see hemorrhage from the retinal venules, and there is abnormal growth of blood vessels, that is new vessel formation. The aneurysm, microaneurysm, can give away and it can lead to dot hemorrhages. The leakage can lead to long-standing leakages in nerve fiber layer, can lead to cottonelle spots, and outer plexiform layer, it is called as hard exudates. There is cholesterol deposition. And the hard exudates are bright yellow in color, and the margins are distinct. There is cottonelle spots are white lesions and with fluffy margins. In hyperglycemic patients, there is increased orbital accumulation. So the increased orbital can lead to free radicals glycated end products. There is a disruption of ion channel, and the protein kinase C are activated, which can directly affect the retinal vessels. The microangiopathy, which damages the capillary wall, can give rise to infraretinal hemorrhages, and the edema can lead to exudates. Microvascular occlusion causes ischemia, So in FFA, you can see capillary non-perfusion areas from capillary perfusion areas. So the non-perfusion areas are black in color, and edema is seen. So neovascularization can lead to hemorrhage, can lead to vitreous hemorrhages. Fibrosis can, uh, can lead to tractional retinal detachment. What are the symptoms of diabetic retinopathy patient? Early stages, the diabetic retinopathy patient is mostly asymptomatic. As the disease progresses, it can lead to cataract formation and and the dot and blot hemorrhages, vitreous hemorrhages. With vitreous hemorrhage, the vision is reduced. And when there is macular edema, the vision is markedly reduced. The symptoms include blurred vision, floaters and flashes, distorted vision, dark areas in vision, poor night vision, impaired color vision, and this partial or total loss of vision. This is the visual field of comparing the normal individual with that of a diabetic retinopathy patients. So in normal patients, you can see the vision field is clear, it is full. In case of diabetic retinopathy, the images are blurred, and because these vitreous hemorrhages, they are seen as dark spots. So the patient might complain with black spots, complain of black spots. What are the signs of diabetic retinopathy? So when you examine the patient, you'll be able to see the microaneurysm. Microaneurysm is seen as dot hemorrhages. In FFA, it is seen as non-perfusion. Around the microaneurysm, you can see capillary non-perfusion areas. Retinal hemorrhages can be there. A dark exudates is seen, cottonole spots are seen, venous bleeding is there. So venous bleeding is because of fusion. There is intraretinal microvascular abnormalities, which is edema, which is mostly seen in fundus fluorescent angiography. Macular edema can be seen. Macular edema, long-standing macular edema, you can see hard exudates around macula. And there is tortuosity of your vessels, retinal vessels. Microaneurysm. Microaneurysm is a localized saccular outpoachings of capillary wall seen as a red dot. So there is focal dilatation of capillary wall, but the pericytes are absent. It is usually seen in relation to areas of capillary non-perfusion, and it's mostly at the posterior pole, which is temporal to the fovea. Microaneurysm is the earliest sign of diabetic retinopathy. So, this is the fundus picture where you can see a small dot, red dot is seen above the superior arcade. That is microaneurysm, that represents microaneurysm. Diabetic maculopathy. Diabetic maculopathy, as the name suggests, the macula is involved. So there can be ischemia or edema can be seen. Ischemia, there is retinal capillary non-perfusion is there, and seen in progressive non-proliferative diabetic retinopathy. Macular edema, it can be focal, diffuse, or mixed. This increased retinal vascular permeability leads to macular edema. It's seen in both non-proliferative diabetic retinopathy as well as diabetic retinopathy. Diabetic retinopathy, which is important in planning the treatment. So when the patient is having poor vision and you see a macular edema, you have to do a FFA, and OCT. So OCT is to quantify the macular edema, whereby we can decide on the treatment of macular edema, which is anti-VEGF, or it can be focal or grid laser. So here's a picture showing the fundus and the FFA. So the picture A shows focal macular edema. Focal macular edema, you can see hard exudates around the macula is there. The FFA picture, you can see whitish spots, that is hyper reflective dots can be seen. And in the macula, you can see hypo areas. So below you got diffuse macular edema. In diffuse macular edema, you can see hard exudates. The hard exudates, they prevent the perfusion. Classification of diabetic retinopathy. Diabetic retinopathy is classified as non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy is graded as very mild non-proliferative diabetic retinopathy, mild NPDR, moderate NPDR, severe NPDR, and very severe NPDR. Proliferative diabetic retinopathy is further classified as mild to moderate NPDR, high risk PDR. So, what are the findings we see in non-proliferative diabetic retinopathy? In mild, very mild, you can see at least one microaneurysm. In mild non-proliferative diabetic retinopathy, microaneurysms are seen. Diabetic retinal hemorrhages, that is dot and blot hemorrhages are seen. Exudates can be there, and nerve fiber layer edema, that is quadranole spots, can be seen. In case of moderate NPDR, it includes there is hemorrhages can be seen in more than one quadrant. One quadrant, 1 to 3 quadrants. Microaneurysms are the hard states and quadranole spots can be seen. In severe case, you can the findings can be put as 4 to 1. So 4 quadrants. 4 represents 4 quadrants. In 4 quadrants, we can see hemorrhages and microaneurysm. In 2 quadrants, a venous bleeding should be there. And 1 quadrant, intraretinal microedema, that is intraretinal microvascular abnormalities are seen. So this is the criteria for severe NPDR. So severe NPDR, again to emphasize, severe NPDR, hemorrhages and microaneurysm is seen in 4 quadrants. Venous bleeding is seen in at least 2 quadrants. Edema is seen in at least 1 quadrant. That was about non-proliferative diabetic retinopathy. In proliferative diabetic retinopathy is seen in at least 5% of diabetic patients. The findings includes neovascularization. Neovascularization can be seen in the disc or it can be seen in the around the posterior pole elsewhere. That is called as neovascularization elsewhere. So there can be vitreous changes can be seen. The neovascularization, these new vessels, they are leaky, they can break, they can give away, and which can lead to hemorrhage. So there can be vitreous hemorrhage. And there is vitreous hemorrhage, we show the patient and ask the patient to have his head end elevated. An advanced diabetic eye disease includes uncontrolled proliferative diabetic retinopathy. Glaucoma is seen. Glaucoma is because of neovascularization of iris and around the angle of anterior chamber. Initially, it is open-angle glaucoma. As the disease progresses, the neovascularization we can either be, they can fibrose and then can lead to annular glaucoma. The blindness can be because of persistent vitreous hemorrhage, fractional retinal detachment, and membrane formation. So here you can see uh, new vessels disc on the right side, where there is capillary loops are seen around the disc and inside the disc. On your left hand, you can see same capillary loop or new vessels in the posterior port. This is a fundus picture showing new vessels around the disc. Periphery, you can see, and periphery and the macula, you can see non-perfusion areas. So there is the importance of screening the diabetic retinopathy patient to prevent the progression of the diseases. So in type 1 diabetes, the eye examination should be within 5 years of onset, and type 2 diabetes ophthalmic examination should be done at the time of diagnosis. If there is no diabetic retinopathy, then your patient can be followed up annually. If there is any level of NPDR or PDR, depending upon the level of severity, the review should be, the patient should be examined frequently. In case of pregnant women with diabetes, either type 1 or type 2, should be concerned about the risk of development of diabetic retinopathy and its progression. When should we start the eye examination? Eye examination should be started from first trimester and monitored every trimester for 1 year and 1 year after childbirth. Management of how do we manage diabetic retinopathy? The management includes medical management, observation, laser therapy, anti-VEGF, vitrectomy, and intravitreal anti-VEGF agents, that is bevacizumab, ranibizumab, aflibercept. In case of very mild observation, very mild diabetic retinopathy, then observe the patient. In case of mild vitreous hemorrhage, you can reassure the patient. If it is very severe, long-standing, PPD can be done. The medical management includes glucose control. So our aim is to maintain the HbA1c level at around 6 to 7%. So the level of activity, so patient should be advised on improving their lifestyle with the regular exercise and diet. And BP control in case of comorbid hypertension, patient should be advised to control the BP, and lipid lowering therapy should be given if the TG level is increased. So laser therapy includes pan-retinal photocoagulation and focal or grid laser. Focal or grid laser is given in PSME, cystoid macular edema, central cystoid macular edema, in central serous macular edema, here, and PDR. Pan-retinal photocoagulation is given in high-risk PDR cases. There is vitreous or pre-retinal hemorrhage, new vessels of this or within 1500 microns from the optic disc frame. So this large new vessels can be seen in handwritten photocoagulation. So we are converting the retina into hypoxic state so that the new vessel formation can be prevented. Limitation includes the patient must have clear lens and vitreous. There is cataract, then patient should be advised to undergo cataract surgery before laser PRP. In case of vitreous hemorrhage, vitrectomy can be done, and laser photocoagulation can be done. The surgery includes pars plana vitrectomy. So when do we do pars plana vitrectomy? It is done in severe persistent vitreous hemorrhage. There is progressive tractional artery which is threatening or involving the macula. And there is tractional, combined tractional and tegmatogenous artery. There is premacular subhyaloid hemorrhages. All these are visual threatening situations. A recurrent vitreous hemorrhage after laser PRP, so that we can treat the patient with pars plana vitrectomy. So vitrectomy, three ports is there. One port is for the for light, and the other port for infusion and cutter. Vitrectomy cutter. So the vitrectomy cutter removes the hemorrhages and the vitreous, thereby allowing PRP. Hypertension retinopathy, the fundus picture is very much similar to that of diabetic retinopathy. So there are few differentiating points. Hypertensive retinopathy, one can see dry retina. Diabetic retinopathy, the retina is wet. So what do you mean by wet? Wet means there is multiple hemorrhages are there, extensive edema is there, multiple exudates are seen. In case of hypertensive retinopathy, hemorrhages are few. Exudates can be there. And hypertensive retinopathy, multiple cotton wool spots. Diabetic retinopathy, few cotton wool spots are there, and few flame-shaped hemorrhages. Hypertensive retinopathy, flame-shaped hemorrhages are present. In hypertensive retinopathy, uh, you can see abnormal retinal arteries. Arteries are involved. In diabetes, the veins and capillaries are involved. So that was about diabetic retinopathy. Thank you.